Well, welcome. I'm Dr. Kent Sasse. Thanks for spending a little time today looking at this webinar where we'll discuss weight loss surgery. I'm going to describe a little bit about how the field has evolved here over the years and where we are today offering what is the safest, simplest, and arguably the most effective weight loss procedure today. I start with this slide describing what we call 50 minutes to healthy, and that's really taken from the notion that the procedure itself just takes about 50 minutes to perform. That's a lot less time than people sometimes imagine, and sometimes when I'm speaking to medical audiences, physicians don't realize that we're no longer dealing with surgery that takes 4 hours or that was open surgery. We're dealing with a relatively non-invasive intervention today that pays big dividends over the long period of time, but the surgery itself just takes about 45 minutes or 50 minutes. And Jody there, you can see in the photo, is a patient of mine who's done beautifully after her sleeve procedure, and I'll show many other examples as we talk just to kind of illustrate some of the points. But let's start by asking what your goal is. We doctors oftentimes frame the questions in terms of medical reasons or rationale. In this area of excess weight or obesity, we often think about diabetes, blood sugar, blood pressure, bone and joint problems. But really, this is more about you and your life and where you hope to be and what things you hope to gain from it. So I was kind of reminded of that when I was meeting this lovely person, Diana, for the first time. She came to see me with a desire to lose more weight. She'd been working at it quite a bit, had kids and a family to look after. And I asked her what her goals were, and these were the things that she described. Being healthier, feeling more energy, more active, being a better partner, mom, living longer, and then running a 5K, which I thought was a great goal. So towards the end of this webinar, I'll circle back and kind of show you what became of Diana and the things that she's been able to accomplish and how those have kind of inspired us and me. This is a brief outline of the things I'll cover here, including a little bit about our group, about the problem of weight gain itself. We'll just discuss what is the BMI, a little bit about the health risks of staying the course. So anytime someone is considering a new procedure or a new treatment, you have to weigh the pros and cons or the risks and benefits, but you also have to examine what are the pros and cons of staying the course and not doing what the recommended treatment is. So in this case, I'm describing what is nowadays the recommended treatment for excess weight over, say, 50 pounds or 70 pounds overweight. And I'll show you that the recommendation has become very strong in recent years, as described by not just bariatric surgeons, but the American Heart Association and a lot of supporting literature around the world and many medical societies that don't really have anything to do with weight loss surgery. But I'll also take a little time to examine what are the health risks of staying the course and not doing what we believe is the recommended treatment today. And then for many people, why they really are watching this is to learn how you might achieve permanent weight loss and starting today. What steps can you take today to do that? So I'll try to mention what those things are today so you can get moving on it. This patient, by the way, who's in the uniform is a security guard at one of the hospitals where I've worked for many years. I did his weight loss surgery many years ago where he looked like that on the left. He was taking medicine for diabetes. I think he's a good example of somebody who really has embraced the notion of the recommended physical activity every day. One of the things you'll hear me say several times is that to be successful, you really need to try to engage in more physical activity every day, 7 days a week, even though you may be limited by bad knees or hips or back or other disabilities. You just find a way to be creative and try to get more exercise. And hopefully with the weight loss, you have a virtuous cycle where you can do more and feel better and lose more weight and continue that. So he was the kind of security guard who was watching the monitor a lot, sitting on his chair a lot, but now after the surgery, he's the kind who's walking around the property a lot. So I see him making his rounds, being physically active every day. It's a blessing that he's been able to do that at his work. A lot of people don't have that opportunity, but I think he really illustrates why here he is 12, 14 years later, he's kept the weight off and continues to do what 75% of people do after weight loss surgery, which is maintain the weight that they've lost. So I think he's a good example. I trained at UC San Francisco. I was in my training there kind of during the heyday or the real explosion of minimally invasive or non-invasive surgical interventions. So I trained with the best, really had a great education there, and then did fellowship training in more advanced laparoscopic or minimally invasive abdominal surgery in Boston before coming here to Reno. And I've been here faculty at the University School of Medicine and the director of the accredited program here in Northern Nevada, and performing the first gastric bypass operations here in Northern Nevada, and have been very deeply invested in this now for many years, over 16 years, really 17 years. I'm certified by all the boards you'd want to be certified by, and a fellow of the American Society of Metabolic and Bariatric Surgery, which is a fairly rare fellowship certification. But I'm really surrounded by an exceptional team, and that's really what makes this such a pleasure to work in this field, but also to be able to offer a really great program and really great success rates for people who entrust us with their care. So the challenge today is really that obesity causes a number of health problems, and there's really over 90 specific health conditions that have been related to obesity specifically. We know that obesity causes the majority of diabetes. So type 2 diabetes today affects many, many people in the United States and around the world, and this is directly attributed to obesity in over 80% of cases. It also causes poor health in many other ways and reduces our quality of life. As we answer in surveys, we report to researchers that we have lower quality of life when we're heavier and better of quality of life when we're skinnier. No big surprises there. But one thing that's kind of new in the last 10 years or so is this notion of the physiologic set point. And I'll describe that a little bit more. But basically what we've learned is that in order to be successful, in order to break through and help people lose the weight but then keep it off, we need to do something specific, and that is to change the physiologic set point. That's the mechanism of the body that pushes our weight back up when we try to lose weight, when we try to diet and exercise and chip away at those pounds. We have mechanisms in the body that push it back up against our better desires and our health. And I'll describe a little bit about why that happens. But what we know today unmistakably is that in order to change weight permanently, we need to change the set point. And today that requires a surgical procedure. It requires doing something that changes the stomach. There's no medication, there's no herbal remedy, there's no exercise that does that, unfortunately. In future years and decades, I hope that we will have better science that allows us to make a dent in this set point problem. But until then, the solution is with a less invasive surgical procedure combined with a comprehensive long-term program. That's really the holy grail for successful weight loss. The good news is that it is a highly successful plan. So let's talk a little bit about it. As I say here, the solution is a less invasive procedure combined with the comprehensive program, and I've kind of listed here some of the people that are associated with helping you through that journey and making it successful. As I say here, the system, as we call it, is a plan that consists of both a diet plan and an exercise plan for the long term, and then some regular vitamin testing and some long-term follow-ups with weighing in at our place every 3 months or as often as you can come in. People do a minimum of annually. We'd like to see everybody every 3 months forever. But certainly those regular check-ins are helpful, we think. We also say know your metabolic rate. This refers to a test where a person has their metabolic rate tested with a breathing test that's done right in the office. Used to be a big research test with a lot of equipment, but now it can be done in about 15 minutes in the office. And this gives you a number that tells you how many calories your body is burning every day. And so it's helpful to kind of get an idea of what your sort of calorie allowance is, how much you may be able to eat on a regular basis and not go over the threshold whereby you'll be gaining weight. And so it's a good guideline. We're not really big on counting every single calorie, and our philosophy is to know the general ballpark of where your calories are, but focus more on keeping the carbs down to a minimum and focus, generally speaking, on your exercise and keeping the portions to a reasonable level. The system also emphasizes meal replacements and using the tools that have been crafted by some experts out there that help us suppress our appetite and help us get in good nutrition without getting in a lot of carbohydrate calories. So when I refer to carbs, I'm talking not just about sweets, which would be desserts, but also sugared beverages, juices and sodas and things like that, but also the breads and crackers, all of those things that have carbs, and the body treats them basically just like eating sugar. It causes rises in circulating blood sugar and triggers the hormones that we think are mostly associated with weight gain. So use the tools like the tubs of protein powder meal replacement shakes that you see depicted there. There's lots of them out there today. Good flavors, they're tasty. I have them almost every day for breakfast, and it's very appetite suppressing. And then really commit to this minimum of walking 30 minutes a day. We aim for 45 minutes a day as kind of a minimum for everybody, but at least start with 30 minutes a day of walking. If you can't do that because of some disabilities, then focus on what you can do. Maybe it's some light 5-pound arm hand weights, or maybe it's getting in a pool 3 days a week. Just be creative, but be persistent at trying to find ways to get more physical activity every single day. And then a diet that emphasizes minimizing carbs, but focus on what you can eat, which is vegetables, 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 and lots of protein items. So A lot more about that in a book that we'll give you when you come to see us, but for starters, that's where you'd want to begin. So the next slide talks a little bit about that set point, and what you see depicted here is a study that comes from the University of Cincinnati that talks about what happens with the set point. And in this study, which was done in animals, but it's been replicated in humans, I just show this one because it's a pretty famous study. So the animals in the black were given the so-called normal food supply, but the animals in the blue were given a restricted food supply. They were put on a diet, just like you or I might do if we were on a diet. And what we saw was that over the first 140 days, the animals on the calorie restriction did lose weight, just like we do when we're on a diet. But then at day 140, they were put back with the normal food supply thereafter. And it's important to note that they weren't given extra portions or triple portions or given all the meals that they missed. But what happened was right after that, very quickly, they regained all the weight that they had lost. And researchers noticed that it took them 140 days to lose those pounds, but it only took them about 10 days to regain all that weight again, just with the normal food supply and not any excess calories. So this is very much what people have told me over many years, that they will diet and work really hard at losing weight. At some point, whether it's 3 months later or 6 months later, they will go back to eating some regular food again. And very rarely do people go on crazy binges and eat all the meals they missed or take in triple portions and desserts, but they just started eating regular foods again, only to find that the pounds came back on with a vengeance and very rapidly. And I've had many patients over the years say, I told my doctor this, that I dieted for 6 months, worked really hard at it, lost 50 pounds, and then when I went back to eating some regular food again, I regained all that 50 and even 55 pounds, and it only took me 3 weeks to do that. And I say, Doc, how could that happen? And I find that they don't believe me. But I think today we do believe that. We know it happens. This is really the physiology. This is really the set point in action. What happens is a set of mechanisms, hormonal mechanisms and regulatory mechanisms of our metabolism kick in that push our weight back up. And you see this happen over and over again. It's very hard to break through and keep those pounds off without doing something that'll interrupt that set point. And we know that now in humans even more strikingly from studies like this one that describes the lessons from The Biggest Loser. Last year, the National Institutes of Health published a study that got a lot of international press by looking at all of the contestants from The Biggest Loser 6 years earlier. They then followed all of those contestants in the following 6 years and measured some key regulating mechanisms, including the resting metabolic rate and some important hormones that we think are involved in weight regulation and the set point. And what they found was very striking. What you see here is that the resting metabolic rate plummeted when the people went on the very vigorous diet and exercise regimen of The Biggest Loser. You may be familiar with the show. The contestants go on a strict calorie restriction diet, and then they exercise many hours a day, and they do lose weight. But what happens is that the body turns down the resting metabolic rate, and so that makes it very difficult to keep the pounds off over time. And predictably then, the contestants regain their weight. So you may be familiar with the fact that they did regain their weight. Nearly all of it was regained. The average is actually brought down a little bit by one of the contestants, which is Rudy, you may know from the show. That contestant, Rudy, as he started regaining his weight, he did have weight loss surgery, and he did then lose a lot of weight, which brought down the 6-year average quite a bit. Also, interestingly, his resting metabolic rate, his metabolism had gone way down like everyone else's, but when he had weight loss surgery, it went back up. And so that's an example of how the set point changes with weight loss surgery. Instead of the resting metabolic rate plummeting like this, it actually stays where it should be. It's at the expected, or it even creeps upward a little bit. And likewise, the hormones that are measured, which are going just the wrong direction after the diet and exercise plan, which tend to make us regain weight, make us more hungry, make us store more fat. Instead, after weight loss surgery and after the sleeve procedure in general, they're actually generally moving in the right direction. They're making us less hungry and less likely to regain the weight. And so these are the lessons that we've learned from studies in the most modern era now that examine diet and exercise. And it helps us understand why it's so difficult and so unlikely statistically that someone can lose 50 or more pounds and then keep it off over time without doing something to interrupt the set point. So historically, the medical view of obesity has really been one that's pretty disgraceful, and I just apologize collectively for the medical professionals who've talked about character and willpower, when really that only has a small amount to do with it. Certainly it takes character and willpower to stick with it, and we emphasize a lot that it's important to stick with the diet and the exercise regimen. But really this problem of excess weight and afflicting so many millions of people stems from a big change in the environment around us and in the food supply around us. And so we see today that the implications for treating excess weight have changed markedly, and now we believe, and the medical community believes, that we must use an individualized approach and we must work to have early surgery brought to bear, because this is the most effective tool. You see these recommendations in societies from as diverse as the American Heart Association to the American Diabetic Association and many others in between. And so when I say 50 minutes to healthy, what I'm really describing is the mechanism by which we change that set point, and we change those very unfavorable odds of losing and keeping the weight off to highly favorable odds of losing and keeping the weight off. We look at research that shows across many countries that with the sleeve gastrectomy procedure, the odds are about the same as they are with gastric bypass procedure, which is that about 99% of people will lose a lot of weight, and about 75% of those people will keep that weight off at 10 years. So is that perfect? No, it's not perfect, but it's by far the best tool we have today to make a big impact, add years to people's lives, and improve their health. The 50 minutes describes the procedure itself, which involves those small incisions, the rapid recovery, less pain, less risks, and indeed the procedures today do change that physiologic set point, and we think permanently so. So our group is really committed to the quality and the excellence of this whole enterprise. You saw a little list of the team with whom I work, everyone from the psychologist to the support team to the dietitians to the physician assistants and the research collaborators and all the people in between who really make this successful. Each of them is very committed to the success of it and to your success, battling through the insurance hurdles and all the things we have to get through, but then also the long-term counseling and coaching so that you'll be successful keeping that weight off over the long term. You're not alone. This is really a widespread epidemic, as these statistics describe. About 2/3 of people are battling with either overweight or obese, and lots of children are battling this problem too, about 1/3 of kids in Nevada and around the country. As you see from the graphic depictions of the United States, if you looked at 1997 data, the Centers for Disease Control kind of outlined where we see the prevalence of obesity. But if you went back 10 years, you really saw that this was far less prevalent. So this is really a rapid change stemming from an environmental change in the food supply, from the genomics of food and foods like wheat and corn and other staples, and also to things like portion size and the taste and richness of the foods that we consume. But if you go back to 97 and then we go forward now, you look at 2007, you can see how quickly this has overtaken the United States. And here in what I've depicted in 2014, you see Nevada there is kind of right in the middle. California does a little better, but really this is a nationwide problem. So I mentioned the CDC defining prevalence of obesity by using one number, and that number is the body mass index, or the BMI. So BMI is really a number that was invented by the life insurance actuaries. Those are the mathematicians who crunch numbers to try to figure out how long we're expected to live in order to calculate life insurance premiums. And what they came up with was a pretty simple formula that had kilograms per meter squared, or weight divided by our height squared, to give us a number that put us in categories of weight and health. And as BMI rose, they found that longevity diminished. So life expectancy really tailed off, especially once you get to a BMI of 35, you see life expectancy really plummets. And so we now know that BMI 18 to 25 is considered a, quote, normal BMI, not because of any sort of social judgments or thoughts like that. It's purely on the basis of life expectancy, and it also correlates very closely to disease incidence, particularly diabetes. BMI over 25 is considered overweight, and then BMI over 30 is considered obesity, as at least as defined by the CDC and other health entities. The reason it's important is because that's used for kind of determining what treatments might be approved, when the FDA might approve treatments, when surgery might be considered. This graph just depicts what various levels of BMI sort of look like in terms of height and weight. And then you just see this fact that's represented here. This came from the New England Journal of Medicine that got a lot of press and discussion in the media because it showed how quickly life expectancy plummets over a BMI of 35 which really gives impetus to being much more serious about treating this problem. And since we have such good tools today to treat this problem, we can really improve people's quality of life, but also their longevity and life expectancy. So who qualifies for weight loss surgery? Well, in this graphic, I've drawn the box around a BMI of 30, and I've done so because there are so many studies demonstrating that if one has weight loss surgery at a BMI of 30, that person will live longer and have a healthier life ahead than if they don't have weight loss surgery. I've also drawn it there because the FDA has drawn the box there with its approval of devices like the lap band, which is a device that is placed around the upper stomach, and also more recent devices such as the intragastric balloons. I don't talk much about that here in the webinar today, but let me just briefly say that that's a device that might be a good consideration for somebody who needs to lose 30 or 40 or 50 pounds. It's not covered by insurance yet, but it is certainly an FDA-approved device. So that's something for that kind of person with a lower amount of weight to lose. But certainly insurance begins to pay for weight loss surgery at a BMI of about 35 in most cases, and normally by a BMI of 40 we see all the insurance plans covering weight loss surgery at that point. I should say that not all insurance plans do cover weight loss surgery today, although we wish they did so. But it's much more than it was 17 years ago when I first started doing this. Over 80% of people in our community in Northern Nevada have coverage for weight loss surgery either through public plans such as Medicare, Medicaid, TRICARE, or other public employee plans, or through their commercial plans through their employers. And the reason that insurance plans do cover it and that these recommendations have become so strong have to do with the decrease in longevity that we saw, but also the health risks of untreated obesity. So those risks include the 90+ medical conditions that I described, some of which are listed here. Probably the top one we often mention is type 2 diabetes. We talk about it a lot because type 2 diabetes is so common, and because it's the number one cause of blindness, the number one cause of amputations, the number one cause of kidney failure. It leads to so many things that it really has a huge impact on health. And since we have this treatment that normally resolves diabetes in most people, it's just important to get the word out that that we have this intervention which can be so impactful in improving people's lives. But also cardiovascular disease, which relates to strokes and heart attacks. Many kinds of cancer is listed, and this is just a small sampling here. It's also personally costly to battle excess weight and obesity, at least according to this one study, which tabulated the costs that people were spending out of pocket to battle excess weight with all the things they were doing, going to Jenny Craig and buying supplements and diet plans, etc. But really the idea of the risks of staying the course are most well told in studies like this one, which was a 5-year study examining 2 groups of people. One group that was people who chose to have weight loss surgery and were followed for every day to the end of 5 years time frame, and the other group which were very carefully matched to the first groups in the sense that they were the same age, the same weight, the same health characteristics, same gender, etc. And so these 2 groups that were carefully matched were followed prospectively for 5 years. And at the end of 5 years, the researchers tabulated all of the health problems that accrued or came up during those 5 years in 40 categories. So everything you can think of head to toe. And I've just depicted one slide here. This is just the first 5 categories, but this goes on for 35 more categories, and it looks just like this, where the light blue you see are the one group, and they had anywhere from 3 to 10 or 11 times as many health events, whether it was a sprained ankle or a full knee replacement, whether it was a minor chest pain or a major coronary artery bypass surgery. Everything like that was encapsulated and recorded in this study. And what they found was that one group had many, many, many times more health events across every single category than the other group. And by now I'm sure you know which group is which, but I'll just tell you that the group that had so many more health events, adverse health events in the 5 years that followed, was the group that stayed the course and did not have weight loss surgery. And those people still were working at it with the Weight Watchers and the diet plans and the exercise and seeing their doctors and even taking medications, and any other thing that you could think of was certainly available to them, and as most of us are doing, they were working at doing that. The other group that had weight loss surgery, had far fewer health events over the course of those 5 years, and that added up cumulatively to this data here, which showed the mortality risk at the end of those 5 years. And as you can see, the people who stayed the course had about a 6.17% mortality risk at the end of the 5 years time frame. But the people who had had weight loss surgery, their mortality risk, the risk of dying over those 5 years, had plummeted over 9-fold, nearly 10-fold, to 0.68%. So you can see what a dramatic impact this has on life expectancy just by undergoing that weight loss surgical procedure. And you might say, well, maybe that doesn't include the complications of the surgery itself, but indeed it does include those complications. The researchers did roll that in and included the mortality risk that stemmed from the surgery itself, which they reported, and I've put in the slide there, was 0.4%, which would be considered far higher than a mortality risk expectation than we would have today. For example, we've had over 1,200 consecutive sleeve gastrectomy cases, and we've never lost anyone, so the risk is way under 0.4%. Right now it is 0.0%. So you can imagine that those statistics are even more accentuated today than they would have been when that study was conducted in the early 2000s and late 90s. So for all those reasons that I've kind of described, you see these recommendations for weight loss surgery that have emerged from societies across the board. I've just given a small sort of sampling here, but included societies like the American Heart Association and American Diabetes Association. And you can go to their websites and review their recommendations and kind of how they phrase it and at what BMI they recommend it. But what you see today is a very strong consensus around the notion that weight loss surgery has become safer, and it is demonstrably highly effective, and it reduces people's risks, improves quality of life, and extends life. And today those facts are very compelling, and those are the reasons we're here where we are today. So let's talk a little bit about the weight loss surgery itself, and as I describe here, weight loss surgery evolution. Back in 1985, approximately, you saw a real emergence of Roux-en-Y gastric bypass. Many people have heard of this. This was very widely performed and still is to some degree today. In 1995, we saw the emergence of something called the lap band, or the adjustable gastric band. This was FDA approved in the United States in about 2000, and we did quite a few of them in the early years. And then much more recently, in about 2005, we saw the emergence of something called the sleeve gastrectomy, or the vertical sleeve gastrectomy. A lot of times we just refer to that as the sleeve. And that's really become the dominant procedure today, and I'll describe why that is. But let's take a look at these one by one a little bit more. These illustrations are going to describe each of the procedures and what goes on anatomically, and I'll just kind of walk you through them. Let's go back to 1985 and look at the Roux-en-Y gastric bypass operation. What you see in the illustration here is that the food comes down where the red arrow is depicting into a small stomach pouch, and the surgeon has created a smaller stomach pouch, so the volume of the stomach is less, so we tend to feel a little fuller and eat less. But then what happens is that the food passes into the roux limb, or the intestine, which has been brought up and connected to the stomach pouch. And that is depicted by the ongoing red arrow traveling down where it meets the digestive juices and travels downstream. And there are several things about this that have made it very successful, and it too kind of carries these statistics of perhaps 99% of people losing a lot of weight initially, and around 75% of people keeping that weight off at 10 years. And the reasons, as we've looked back now with more knowledge about the set point, we think that there are two key reasons why gastric bypass was so successful. The first was that the stomach became smaller, so that probably helped especially early on with satiety and eating smaller portions. But probably the real magic of it came from the fact that the area of the lower outer part of the stomach, the part that is bypassed, is the area that is most active at secreting the hormones that regulate excess weight and obesity and metabolism. And the food really never comes down and tickles the lining of that area anymore because it bypasses that. And since the food never tickles that lining, it never stimulates the secretion of those hormones. And so we think that's the main mechanism by which the set point has been interrupted and why people are able to keep that weight off where they wouldn't have been had they just lost that weight through diet and exercise. If we look ahead at the ways in which bariatric surgery impacts health, we see numerous studies, really thousands of studies nowadays, that show data like this, where they show resolution, complete resolution of quite a few health problems, including diabetes, but many others along the list, and then improvement in the same health problems for most people across the board. So really nearly 100% of people with diabetes will see some significant improvement, if not complete resolution. And there you can sort of read each different health condition and kind of see if some of those might relate to you, or if there are things that you know or maybe on the horizon that parents have had or are approaching in the near future. This is just a slide depicting some specific studies that outline those health improvements and how they get better and to what degree they get better after weight loss surgery. Same thing is true here for men, depicting similar conditions, but some of which are just affecting men. Like all surgery, though, the gastric bypass has some pros and cons. So there are some big advantages, and I kind of highlighted those with the long-term success of the weight loss and the improvements in diabetes, the long experience in the United States. But the reason why the gastric bypass was not perfect and why it left room for improvement were those disadvantages that I've described here on the right-hand column. It's a more technically complex procedure. There's a rerouting of the intestines. There's a risk of blockage or internal hernia formation. And then there's a bypass going on, which means that we don't absorb some of our nutrients. And some of those are good nutrients. So we don't absorb some of the micronutrients and vitamins and minerals that we would like to have. And as a result, some people can develop some severe and very troublesome vitamin deficiencies. We've had a number of people over the years who have had to have IV infusions of vitamins in order to try to correct those, and it's not always that easy. So that's left some ways in which we'd like to be able to improve upon that. And if you sort of think back to those key features that make gastric bypass so successful, namely the smaller size of the stomach and then the big impact on changing the set point because of the change in the food's access to that one outer lower area of the stomach, then you'd say, if we could do that somehow, but do so in a way that didn't involve the rerouting and didn't involve the malabsorption, well, then we'd really have a huge success. So keep that thought in mind as we move forward here. And this is just one of, as I say, thousands of patients of mine. I did over 3,000 gastric bypass operations, so I was not a quick, easy convert to any other procedures, but really have many, many people that we continue to see and enjoy and look after and check vitamin levels for, including people like Gail, lovely folks who've done beautifully with gastric bypass. But as I say, as the data has continued to grow, we have gradually shifted more focus to the sleeve, and I'll describe why that is as we get a little closer. But let's take a little time here to talk about gastric banding, which, as I said, came out in about 1995 and came to the United States in larger numbers in around 2000. And what's depicted there is a removable and adjustable band that's placed around the upper stomach, and it creates a sense of satiety so that we tend to eat less, and it has been successful and a less invasive intervention, at least up front. The sort of initial invasiveness appears less. And as you see from these illustrations of the band itself, there are these kind of soft pillowed sort of balloons or cushions, and as saline is added to the system, those will squeeze around the upper stomach, and this can help create a greater sense of satiety. The weight loss tends to be more gradual over time, as is depicted in this slide. And in one study, this one in particular, I always show since I was one of the authors of this study, I was one of the investigators, the weight loss became a little bit more rapid and successful with the new generations of the band that came around. But if you sort of take a bird's eye view and step back, you realize that large multi-year long-term studies like the Swedish obesity subject study that looked at banding and looked at procedures like the bypass or sleeve data, and also, by the way, compared it to medically supervised weight loss programs, you'll see that the banding is really, globally speaking, not as effective at inducing weight loss as the sleeve or bypass would be, as depicted in the sort of green line there at the bottom. Interestingly, people who had medically supervised weight loss programs in Sweden over 15 years really didn't lose any weight at all. In fact, they gained some weight. People who had banding did lose some weight, and certainly that is to be credited for helping people lose some weight, but it surely lacked the sort of impact and the magnitude of effectiveness of a bypass or sleeve procedure today. But back when the choices really were a possibly less invasive band with approximately half the weight loss expected, or a more invasive bypass with more weight loss expected, that was a sort of a reasonable choice to make. But I think today what you find is that you have a procedure that is much less invasive, arguably akin to the band, with far fewer complications than the bypass, but with the big impact weight loss that is equivalent to that of the bypass. And so for those reasons, we've sort of moved forward in that direction. So the banding has its pros and cons, just like any procedure. The advantages I've kind of listed there on the left, and the disadvantages I've listed on the right, which are that the overall magnitude of weight loss has been less in the largest studies. It does involve an insertion or implantation of a device, which over time we now see from more recent studies and more sort of longer term studies that once you get 10 or 15 years out with the band, that there's a much higher rate of its needing to be removed because of side effects. So we know now that we need to keep the band a little looser than we once thought. We know that those side effects can be worse if the band is very tight, but we still see problems like aspiration or reflux, vomiting, and we do see cases of erosion where the band is eroded through the stomach and therefore needs to be removed. So it's not without its pitfalls, and it is certainly not perfect. And if you could have a procedure that was similarly non-invasive up front, but had the long-term continued non-invasiveness of no implanted device, but yet had the big impact, high amount of weight loss of a more bypass type procedure, well, then you would really have sort of the holy grail. And that's kind of why we've hit upon this latest procedure, which is called the vertical sleeve gastrectomy. So let's talk about that one because that's the one, of course, we're emphasizing the most these days. The anatomy is depicted as you see there, and what is taking place is that the stomach is being partitioned into two sections. One is that sort of banana-shaped stomach where the red arrow is going down and food's being digested. But then nothing is taking place beyond that. There's no change in the intestine whatsoever. There's no rerouting. There's no bypass going on. There's no alteration below what's called the pylorus, which is right at the bottom of the stomach as it empties out into the duodenum. The outer part of the stomach there is trimmed off with a surgical stapling device, and then it is simply removed entirely. And so what we're left with is a smaller stomach, but perhaps more importantly, we're also left with that critical outer lower part of the stomach that we think is kind of the epicenter for secretion of the hormones that regulate weight and metabolism. That's now been removed. And so not only does food not go tickle and stimulate that area to secrete those hormones, but that area has been removed entirely. So you have this profound interruption in the set point mechanism that would otherwise push our weight back up after we've lost it. And so for all of those reasons, we see those same kind of numbers that we saw with gastric bypass. About 99% of people lose a lot of weight, and we think about 75% of people will keep it off at 10 years. This illustration just describes the procedure being performed. There's been some nifty engineering that's enabled us to perform the procedure. There's never a drop of any gastric juice in the procedure because that stapler keeps the walls closed together and deploys 6 rows of surgical titanium staples, which are inert and nobody's ever reacted to them. We don't have allergic reactions to them. They simply close the tissues and the tissues grow around them. What's not depicted there is a calibration tube inside the sleeve that makes it just the right size, not too big, not too small. And for that reasons, we've really been able to kind of regulate and standardize the procedure to make it successful for everyone. So as with any procedure, there are pros and cons. The pros would be that now we have excellent 10 to 12 year data. We have results that show that the sleeve is on par, essentially equivalent to that of gastric bypass in terms of weight loss, but also in terms of the more important features of resolution of disease such as diabetes. And we see that we don't have the malabsorption you see with the bypass procedure. We have very small degrees of malabsorption of things like vitamin B12 that require a gastric cofactor, and these have thus far been very easily supplemented with just oral vitamins instead of any kind of IV infusion necessity. Are there disadvantages? Sure, absolutely there are disadvantages. The one that we talk about as being the most frequent problem is kind of something that we accept as being part of the deal, which is that about 2% of people will experience a stenosis. What stenosis means is that there can form a little scarring that can create a bit of an hourglass phenomenon and a tight spot in the sleeve. So instead of looking like a smooth banana, it might look like an hourglass. And the tight spot there can require an endoscopic stretching. There are balloons designed to help us do that. And so I may need to go back in the first month or two and do an endoscopic procedure and stretch that out. That doesn't require surgery or cutting or incisions. There are other potential side effects. Those are mostly over the short term. And then we think the long-term sort of path is very similar to that of gastric bypass, with the exception of the fact that if you do return 10 years later and have regained weight, as people have done with gastric bypass or other procedures over the years, It's not the end of the world. We still have many options available to us at that point because there has not been any major alteration of the anatomy. It's just that your stomach is smaller at that point. So we could, for example, still do a bypass procedure. We could still convert it to anything else that's come along in the interim. And that's really a kind of a unique advantage of the sleeve. We think you just haven't burned any bridges. So globally speaking, there are risks and possible complications with any surgery. You should keep in mind that the risks of a sleeve procedure today are markedly lower than that of things that many overweight people are facing, such as a knee replacement operation or a hip replacement operation or a ventral hernia repair or even a gallbladder procedure or a C-section are generally speaking on par or even higher risk than the laparoscopic sleeve procedure, which we perform in large numbers very safely and now over many years. And as you see here, people like Jody have done beautifully with their sleeve and continue to keep that weight off even years later. What I've depicted here in a few slides are just some large global statistics about improvement in health. This one just mentions hypertension, and about 2/3 of people will have normal blood pressure and off blood pressure medications. About 80% of people will resolve their obstructive sleep apnea. If you're familiar with that, it's kind of the snoring and stop breathing phenomenon that lots of people have and many people don't have diagnosed. And so that resolves in about 80% of people. And then certain forms of hypercholesterolemia can be completely resolved. And then diabetes, we spend a lot of time worrying about and treating and really celebrating when it is resolved, because there's no other real treatment that resolves diabetes. But weight loss surgery has a very high chance of resolving type 2 diabetes. What you see in studies like this one, which we spend a moment just describing, is a prospective randomized study that was done in the United States at the Cleveland Clinic, where people were enrolled, and once they were enrolled, they had a coin flip to determine whether they went to an intensive medical supervision program to attempt to lose weight and improve their diabetes, or they underwent a gastric bypass, or they underwent a sleeve gastrectomy. Pretty amazing to think of these people having a coin flip to determine which surgery they had or whether they even had surgery. But they've stuck with it, and they've continued to report data every year, and so they just recently reported the last data, which was the 5-year outcomes. And as you can see here, the people having very intensive medically supervised weight loss at one of the premier centers in the world under the most intense scrutiny and program did lose some weight initially and did improve the diabetes initially to some degree, but really over the course of 5 years, there's really been very little net improvement. Whereas the people who had a gastric bypass or had a sleeve gastrectomy had profound improvements in diabetes as measured by the hemoglobin A1C, and they are basically identical. You can see the red line and the black line are basically identical all the way out to 5 years. So this really kind of very profoundly confirms that gastric bypass and sleeve gastrectomy have very similar mechanisms and have the same profound impact on resolving type 2 diabetes and excess weight. So other studies have confirmed as well that a high fraction of people will have complete resolution of diabetes. In this aggregate study, over 80% of people experienced normal blood sugars and off medications. And there's many other studies that I show similar findings that I just go through in some detail in the book that I've written and are, of course, noted elsewhere. And many people have resolved these health conditions, and we've been lucky enough to help them get there. I'll also just take a quick minute out. I mentioned earlier that this is a problem that affects children. We've spent a good deal of time recognizing this problem among kids, and in 2005 we formed a nonprofit 501c3 foundation that allowed us to go out and speak to schools and speak and do programs at Boys and Girls Clubs and things like that, just to try to raise awareness in our own community among teachers and parents and stewards of the community and people who interact with kids, to try to get them off this path, because it's going to take a more aggressive effort to help them stay at a healthy weight, because we know that once they've gained a large amount of weight, it's very, very unlikely that they're going to be able to lose that weight without doing something significant like a surgical intervention. So what we want to do is try to focus efforts on trying to help kids prevent gaining that level of weight. And so that's the reason for the foundation. And you may, if you come in and do ultimately end up having us see you, you may be invited to events or asked to participate in some way. I also mentioned supplements earlier on as being a good tool to use in this battle against obesity. I mentioned that I generally have one of these for breakfast every day, and it really quells my appetite for a good 4 hours. This is a great way to kind of have a good, yummy and nutritious snack or supplement without sort of diving into the things that might be available, like pastries and high-carb snacks. Back in around 2006, we were looking around for a supplement that was gluten-free and had no artificial sweeteners, and we couldn't find one. So we got together with a nationally known food scientist and a lab, and we created our own, at that time, what was called, and is still called today, iMetabolic, and there's a bunch of great flavors, and we've had thousands of patients try it, and we've altered the formulas based on those comments. And today we still offer that, and it's a little cheaper than the competitors, and the proceeds that come from that all go to this Childhood Obesity Prevention Foundation, and so that's what we're doing with that. So we ask that you try ours. If you hate ours, obviously there's many others out there nowadays that we think are also good and fit the bill, but we give a little support to this idea of childhood obesity education and prevention through that effort. So this takes commitment, this idea of having weight loss surgery and then being successful with it. It really does take hard work and commitment. The real commitment comes from the long-term commitment to 7 days a week of physical activity or exercise at the level that you can do. And we can help you be creative about finding what that is. It may be that you can do 45 minutes of a brisk walk every day, or maybe even more. Or it may be that you can't do that specifically, but you have to find other ways. It also takes commitment to follow the best diet that you can do, and that means one that's low in carbohydrates. So that's low in sugared drinks and beverages, it's low in desserts, and it's very low in breads and crackers in that snack family. But it emphasizes green and purple vegetables, and it emphasizes protein items. And there's lots of really great, healthy, and delicious things that we can eat and stay on this path, which will help maintain that weight lost over time. And finally, it's critical to continue following up with us, having your vitamin levels checked and stepping on the scale and helping us help you succeed over time. That's the commitment it requires. What are the goals at the end of the day? Well, just to be specific, we would like to see every patient get under a BMI of 30. Why do we say that? Well, the CDC says the BMI of 30 is a disease, so we'd like to see everyone not have that disease. Does everyone get there? No, not everyone does get there, but it's a good goal to set, and so we'll kind of help you find that number on a chart and sort of aim for that. We'd also like to eliminate diabetes if possible, or at least prevent the diabetes. Many, many people who come to see me are pre-diabetic, but they don't know that because you wouldn't really have symptoms from it, but we can measure a blood level, and the hemoglobin A1C will tell if a person is pre-diabetic. So we'd like to, if possible, eliminate insulin use and possible prevent diabetes. We'd also like to eliminate or prevent obstructive sleep apnea and CPAP use in everyone, and the same with hypertension. Many people ask about abdominal wall reconstruction or the tummy tuck and whether they might need that. I would just say that everyone's different. Some people will lose a lot of fat, melt away a lot of fat on the abdomen and then have kind of loose skin there. If it's something that really bothers you, then yes, it may require surgery to remove it. It is something that I do frequently as a part of sometimes abdominal wall reconstruction and hernia repairs, so feel free to talk to me about that at around 12 months or 18 months, and the procedure would be planned at around 18 months or perhaps 24 months. If it's something that would involve arms and legs and skin in other places, there's some excellent cosmetic surgeons in town that I would be more than happy to recommend. So I mentioned a few things during these last period of time you've been watching these slides and hearing me talk. And I would just summarize by saying that we've kind of taken the best elements from past procedures, the very best elements of the gastric bypass procedure with its profound change in the set point, and the very best elements of the band procedure with its early non-invasive or less invasive nature. And we've combined those today in the procedure known as the sleeve procedure, which has delivered the best results that we've had to date. It also keeps your options open for anything that might come down the road. This is generally about a 45-minute procedure for most people. It involves an overnight stay in the hospital, usually just the one night stay in the hospital. Most people are back to work and activities and kind of office level work in about 2 weeks, sometimes even sooner, sometimes a little longer if you have a more physical job or one that's, long 12-hour shifts with unloading and things like that. You might need a little extra time. We think the data is very compelling today that this creates a profound and lasting change in the set point, which is why it delivers those highly successful statistics and why it has earned the endorsements of so many people. This has a marked reduction in health risks going forward and a marked improvement in health, quality of life, and longevity. So we really want to see you achieve your goals, and I mentioned that I would circle back and talk about this great person, Diana, who's been an inspiration to me and to us. And I would just say that she really not only embraced that idea of the commitment and the hard work and did run that 5K, but kept on with her exercise And when in the bottom right photo there, you see I was running the Napa Valley Marathon, which is a 26.2 mile race. It starts up at the top of Napa Valley in Calistoga. You run through the beautiful wine country down to the town of Napa. And who did I see there right at the start line but Diana? And she was running her first full marathon and has gone on to do amazing athletic feats and run other marathons and even a full Ironman level triathlon, and really quite an inspiring person. And so, like a lot of people, I think she and many other people are examples of someone who really has worked at this and previously lost 20 or 30 or 50 or 70 pounds before, only to see it regained, and felt like they just couldn't sort of break through that barrier and get to that healthier weight. But with the surgery, she and so many other people are able to and have been able to. And for that, I think we really take inspiration from them, and we really try to continue to strive to do better. So I showed this slide at the end when we do this seminar live, and we have people ask questions, and I'm happy to answer those. I'm also more than happy to answer those when you come in and see us in the office. And so I would just invite you to take what you've learned here from the webinar, do your own research, but call us, call our office, and come in, and you would meet with me, and we'd work with your health history a little bit and try to determine what the best course is for you. But also you'd meet with people on my team who are experts at the health insurance side of it and what the steps are moving forward in order to reach the surgery and beyond, in order to continue with that long-term comprehensive program to keep the weight off long-term. So I will just leave you with those thoughts and ask you to consider your own goals and where you'd like to be at the end of another 6 months or at the end of another year. What things are important to you, and where do you see your health going if you could lose those pounds and keep it off? And that's something that I think is very likely that you'd be able to achieve with the right procedure for you. I've emphasized the sleeve procedure quite a bit because of its attributes that I summarized here, but there sometimes is a role for those other procedures as well, and so we keep all those arrows in our quiver, and we're able to use the best tool that may apply to you. And so with that, I'll leave you. I'll look forward to seeing you in our office and in our clinic.
So do you have bariatric coverage? One way of finding out is to call the customer service number on the back of your insurance card, contact your human resource department. You can find some of this information in your benefits booklet if you still receive those, and sometimes you can find this online. We've given you the CPT codes for these procedures in order for you to help the representative at your insurance find the information for you. If you do find that this is not a covered benefit under your plan, please give our office a call at 775-829-7999. In order for your insurance to cover your bariatric procedure, you do need to meet medical criteria. If you currently have a private plan, such as a Blue Cross Blue Shield, United Healthcare, Aetna, Cigna, etc., you meet medical criteria by having a BMI between 35 and 39 with at least one comorbid condition. What they consider to be comorbid conditions would be either hypertension, which is also known as high blood pressure, diabetes, and or sleep apnea. If your BMI falls between 35 and 39, you have to have at least one of those in order to meet medical criteria for your insurance to cover. For private plans, if your BMI is 40 and above, there is no comorbid condition required. Medicare and Medicaid Health Plan of Nevada and Medicaid Amerigroup require any BMI of 35 and above to have a comorbid condition regardless. You must have either hypertension, diabetes, and or sleep apnea, regardless if your BMI is above 40. Some insurances require an authorization for a bariatric consultation. The main ones are Hometown Health, Senior Care Plus, TRICARE, and Indian Health Services. Now is a good time for you to contact your primary care physician in order to request that this authorization be put in place prior to your consultation. Unfortunately, without this put in place, we will not be able to see you and will have to reschedule for a later date. There are some insurances that require a referral to be on file at our office prior to seeing you for your consultation. The insurance plans that require this are Health Plan of Nevada, and there are Medicaid and Private Health Plan of Nevada, and both of them will require the referral on file, Senior Dimensions, and Sierra Health and Life. If you do find that you have one of these insurance companies, if you could please give your primary care physician a call and have them fax this over to 775-829-7970. We can then have that prepared for your bariatric consultation date. What happens at your consultation? First, you'll meet with Dr. Sasse and you'll go over your health history and what is your planned or desired surgery. After that, you'll sit down with an insurance representative who will go over your estimated out-of-pocket and will schedule the surgery requirements prior to surgery. Here is what is called your pathway to surgery checklist. These are the items or appointments that are required prior to authorizing surgery. These are also the requirements that your insurance requires for authorization. Everyone is required to have one psychological and nutritional evaluation, a bariatric nutrition class, body composition testing, support group, letter of support and some medical records, upper GI or an endoscopy with Dr. Kent Sasse, and a possible weight loss program. Your advocate at Dr. Sasse's office will help schedule these appointments for you. So just go ahead and keep with your consultation, and on that date, she will meet with you and schedule these future appointments. Just so you know, in our office, we have put together a program where we can do numbers 1, 2, 3, and 4 in our office on one day. Most insurance companies do require what is called a physician-supervised weight loss program. For this weight loss program, it is anywhere between 3 months and 6 months. If you do see your insurance on the list below, we will go through that in detail and your advocate can help outline that process for you. It is 1 visit per month for the allotted time where you and your doctor actively work on a diet and exercise program. Again, your advocate will go through this in detail with you and will help explain how exactly to make sure this documentation is correct for insurance purposes. How long does it take to get to surgery? Well, through an insurance plan, it can be anywhere between 8 weeks to 7 months, just depending on your insurance's requirements or if they have a physician-supervised weight loss program. If you're a self-pay, it can be anywhere between 3 to 6 weeks. We do have a self-pay package pricing for the sleeve gastrectomy, which is $16,900. It is pretty much all in. It does include the facility, anesthesiologist, surgeon assist. It includes all of your classes and testing. There are a couple items that would not be included in that price, and your advocate will go over that in detail with you at the time of your consultation. Once your chart is created, you will be receiving an email that states that you have a health record invite. By accepting that invite and creating your own account, you will be able to update your own health history, view your own test results, request appointments, prescription refills, and messaging. For additional information, please feel free to visit our website at sassesurgical.com. Thanks so much for listening to our webinar. We look forward to seeing you in the office and hope that you have a great, healthy day.